Dr. Wayne Weil. I'm presenting total elbow arthroplasty. This is an 86-year-old female with painful right elbow who has failed conservative management, including steroid injections. The x-rays demonstrated advanced stage osteoarthritis of the elbow joint. The patient is placed supine on the operating room table with the arm over the chest over a padded Mayo stand. A midline incision is made, and the ulnar nerve is found medial to the triceps. The ulnar nerve is protected throughout the case with a vessel loop. It is dissected out of the cubital tunnel and placed into a subcutaneous pocket. Next, the triceps is dissected off of its insertion over the proximal ulna and reflected from a medial to radial direction. Care is taken to take a full thickness of the triceps. Once the triceps and the collateral ligaments are resected, the elbow can be dislocated with hyperflexion. The central portion of the trochlea is next resected with a rongeur, and then the high-speed burr is used to find the opening to the medullary canal of the humerus. The canal finder is next placed into the humerus, and then the cutting guide is attached to the medullary finder, and the appropriate saw cuts are performed on the distal humerus. The trial implant is next used to confirm accurate resection of the distal humerus. Excellent fit of the implant was noted. Next, broaching of the canal is performed, and then a resection of the radial head is performed, as there was significant radiocapitellar arthritis noted. Next, the ulna is prepared in a similar fashion as the humerus. Once the canals are prepared, the implant is trialed. Once the trial implants are removed, final implantation of the implants is performed using a cemented technique. Next, the elbow is taken through range of motion. There's noted to be no significant impingement. The triceps is repaired, and a watertight closure is key to decrease the risk of postoperative infection. The ulnar nerve is transposed anteriorly into a subcutaneous pocket, and the skin is closed in the usual fashion. Sterile bandages are applied, and a well-padded postoperative plaster perisplint is placed. The patient will be seen in 2 weeks' time, and the bandages will be removed, and range of motion as tolerated will be allowed. Thank you for watching this informational video. For more information, you can reach us at Orthopedic Specialists of Seattle or on the web at www.seattlehandandelbow.com or on Instagram at Wayne M. Weil, MD.